welcome everyone. See, we've got Fisher's Health Department, the mayor, all school board members. Janet's going to be coming shortly. Let's stand to say the pledge. The flag is unsealed. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. So my computer is not connecting to the internet right now, but our agenda is pretty simple. It's a work session with the Fisher's Health Department just to talk metrics and some data. Dr. Wolf, is there anything? What is the first agenda item just did?
The first agenda item is to review the metrics.
Review the metrics. Okay, should we start with introductions of the Fisher's Health Department?
Yeah, I'd be happy to provide that. And thank you, President Fullhart, Dr. Borf, school board members. We very much appreciate the opportunity to come before you and have hopefully what is a very productive discussion about the unprecedented times that we find ourselves in. I want to provide a little context and I'll introduce the talented team that we have before you around public health. In March, all of our worlds changed. On March 6th, we were notified that the first COVID patient had reached the borders of Indiana. In fact, the first COVID patient that reached the borders of Indiana found his way to Fishers. So we've been dealing with this from the early part of March. We've all had to make adjustments, sacrifices, adapt, evolve. And during that time, Fishers took the unprecedented step to establish a health department. And I want to talk a little bit about the rationale behind that and where we find ourselves today and what we can bring to the table for you moving forward. First and foremost, the city leaders felt it imperative that public health become integrated with our city. The daily operations of our city going forward will forever be changed, and public health is a key component of it. So the first definition of success for us was to just merely establish a health department, which we were able to do in short time. The second component of that was the integral part of testing. At that time, in March, April, May, June, unless you were symptomatic and at risk, there was no place for you to receive a test. We believed so much in the ability of testing and contact tracing, which from the beginning of this public health pandemic, and if you ask Monica or Dr. Lane or Eileen, every pandemic that's been there, the ability to identify those who are sick and mitigate their ability to expose other people has been a critical part of containing any type of epidemic. So we set up testing, and to date we've tested well over 7,000 people. Nearly 10% of our population has been tested and contact traced. That in itself was an accomplishment from a city perspective. The third chapter was to collect the data from that, and we have done that very successfully. And under Monica's leadership and Eileen's work, we now have a complete picture of what is happening in our community at any given time between our tests and anybody else getting tests throughout the city of Fishers. That is unique to your community. Now, comments have been made through social media and otherwise that we're not sure having that information is a good thing. I find that ironic, sitting in a school, that knowledge would be anything other than empowering if we take the time to understand what that knowledge tells us and have the courage to make the right decisions moving forward. The fourth chapter of this is now that we have this information, we have this data, how do we enable and empower our community to live out the best possible version of their life they can under the circumstances that we find ourselves? And today, we sit here, and I completely understand the unenviable position each and every one of you are in as you make policy decisions around the safety of your teachers, the safety of your children, the undue burden on our residents when their children aren't able to go back to school. We sit here and weigh all of those things, and we can only imagine the difficult decisions that all of you have to make. And our sole mission today is to provide you information and guidance simply from a public health perspective. We are not the superintendent of schools. We are not the school board. We do not understand and know all of the operational challenges that are before you as you try to open back up schools. But we are here to talk to you about the very simple question that every parent has on their mind and every teacher has on their mind. Is it safe to go back to school? And can we achieve in class experiences here at Fishers? And the simple answer is, yes, it can be achieved. But there are things we have to do to mitigate some of the exposures. And today what we want to do is provide you the rationale for where we think we are as a community in terms of the pandemic. And from a public health perspective, what are the things that we can do, the common sense approaches we can take to mitigate any spread of this virus, as well as how are we going to react when the virus does come. And we should all be under no illusions that when you put 22,000 people or some version of that number together in a building, that people aren't going to get sick. And how we address that will define our ability to be resilient moving forward. So with that, I'd like to turn it over to Dr. Indy Lane can introduce her team from the Public Health Department and maybe explain the roles of the individuals. And then they're going to share all this information that's before you today. Thank you.
Good morning. I want to say thank you. It's a pleasure to be here. I have 3 children. They've all been in the HSE school system since they were in kindergarten. I've had the pleasure of volunteering in classes and being a part of this organization, and I can tell you with certainty that I had different perspectives after volunteering in a class. No matter how difficult the C-section or the hysterectomy was, it seemed far easier than 25-year-olds or 6-year-olds. So thank you for your commitment to our children, and I'm grateful for the work that you do. As the mayor said, I'm Dr. Indy Lane. I'm OBGYN. I practice in Indianapolis. I also see patients in Fishers. I also have an administrative role at the hospital, which I think, working with the very talented team that we have, and Monica and Eileen, really kind of helps me keep my finger on the pulse in terms of what the community is feeling, the anxiety around this pandemic, as well as how our hospitals are faring, because in my administrative role, I don't just work as an OBGYN, but I work in coordination with a lot of other different physicians and administrators. So Monica Helps is the leader of this health department. She has worked tirelessly with this team to create, again, the dashboard with Eileen so that we have some information, pulling a team together that can also fulfill the roles of a health department. And then Eileen is our epidemiologist. She keeps us honest with the data and makes sure that we communicate a clear message to you all. And so we're here to serve you, to understand what the challenges are, to provide you with information about public health, and again, just to provide some guidance. And so with that, Monica.
Oh, thanks, Dr. Lane. So we thought we would go through these metrics that we've created. Eileen's going to start by kind of introducing you to some of the data surrounding Fishers, and then we're going to get into what we're proposing here.
Hi, everyone. I'm Eileen White. I'm the epidemiologist working here. I am also a nurse, so some of this together helps bring perspective to a pandemic, especially. So as we move forward, I wanted to start by defining what our community looks like, baseline. So you can start the slides. Looking at the health of our community is the very first piece we need to assess in order to talk about metrics. So what does Hamilton County and what does Fishers look like? As you can see, and I think we all know in this room, it's a great place to live. It has the best health outcomes in the state, and you can see listed there the overall health factors and the ratings of those in the state. So these are important for us in order to develop guidance on how we move forward in our school systems to know what our context is. Here are some demographics, and I just want to draw your attention to this second row. We are a very young community. We have a lot of kids. We are diverse. You can see the differences between Fishers, Hamilton County, and statewide there. And we have 22,000 kids in our school system. So that's something to keep in mind as we discuss what our metrics will look like. Knowing that we are a young community with lots of kids is something we take into account. Next slide. Another piece to draw your attention to is some of the socioeconomic indicators for our area versus the county and the state. So we are a highly educated city, and we have low numbers of uninsured folks, low numbers of folks with a disability as compared to the state. One of the other things I wanted to point out here,
was the poor or fair health, adult obesity, and unemployment numbers for Hamilton County, which are not available for Fishers. But those are things we need to consider as we look at developing metrics for our area. So having done that, go to the next slide, I want to, now that you have that in the back of your minds, that was just a quick look at kind of where we are as a city, as a county, as a state. I want to set the stage for talking about these metrics by thinking about the fact that our city looks the way it does, and that best practices have started to come out from institutions like Johns Hopkins, the Harvard Global Health Institute, the World Health Organization, and CDC. All these folks have come together to develop some of the best practices that we are going to implement here as part of our metrics. We need to take into account a lot of the things that we don't know about this virus. We've only been looking at all of this for 5 months here since March, and this is an important piece of thinking about how we measure things. So we don't know much about how this spreads in schools other than from other countries. And most of those studies that were done in other countries were in settings of low community transmission. So that is measured by a percent positive less than 3%. We'll talk more about that later, but those studies that everybody's hearing about were done in low transmission areas. So we don't know much in our own area about what this would look like. We also have to take into account things like our capacity for testing and our capacity for contact tracing. That's part of that public health capacity metric. As we talk, you'll see that not one piece of information is useful. We have to use many different pieces of information to put together a picture of what we can do to help our community. So percent positive is getting thrown around quite a bit these days, but that's one piece of a bigger puzzle. We have to use these pieces of information, this data, to help inform decisions about how we reopen our communities and our schools. And those metrics and those pieces of information will help us make recommendations to both the schools and to our community on what's safe to do when. So having said that, if you move forward to the next slide, this is what we are looking at. This is the down and dirty of our risk-based rating scale that we've come up with. I want to draw your attention to the obvious here. It is really clear. We have green, yellow, orange, and red. The low risk is the green, and that's considered sort of the maintenance stage of this pandemic for community risk mitigation. And then we have a moderate risk, a significant risk, and a severe risk. I want to draw your attention as well over down to the left side, where we have 3 specific areas that I'm going to talk about as it pertains to these metrics. We have to consider community transmission, we have to consider our public health capacity, and we have to consider our healthcare system capacity. All of those pieces are involved in looking at our community and making recommendations. So let's talk about those top 2 in that first row. These are the metrics that everybody wants to know about. So the first is the positivity rate, or the percent positive. What that means are the number of positive tests over the number of total tests. We, in epidemiology, use this number to give us an understanding of how widespread this disease is in a population if we have widespread testing. So it is directly tied to whether or not our testing is sufficient to identify every single positive case. So I want to give you this background because the more testing we have, you'll see the rates of positives rise because we're able to identify every positive. And as our number of tests go up, you'll then start to see that percent positive come down because we've identified all of them. And then we are able to isolate and contact trace those folks. So it's important to think about that percent positive as part of this context of the bigger testing issue. So that is one thing I really want to focus on. We can identify a widespread community transmission in our area if we look at those numbers. We're saying that less than 5% is within the green zone for our area, given our city makeup and profile. We're using a 7-day average to give us a more smoothed out, better idea of what our percent positive looks like over time. You don't just want to use one day, you want to look at a whole week at a time, really, of this to give you an idea of what it looks like in your population. So that said, there are problems with our testing. We know that we don't test enough in our entire, this is a national issue, right? We have supply chain shortages, we have issues with reagents. These are issues that are affecting our Fisher's testing site, but also affecting even our hospital sites, where we've now started to triage as a country those cases. Those folks who are symptomatic are getting tests when folks who are not symptomatic can't access them now. That's important to note. If we aren't testing asymptomatic people, we're not gonna get everybody. So remember that when we talk about this testing. The other metric I wanted to talk to you about was case incidence. So all this means is new cases. A case incidence is looking at, today we had 5 positives and our population is 93,362. So for today, our case rate would be 5 over our population. What's important about this is more long-term. So if we look at an incidence rate, it matters that we're looking at it over 7 to 14 days. 14 days is really what we want to look at, because it's giving us an idea of whether our cases, we're identifying more of them every day, or whether we're finding them, isolating them, and then therefore our cases are decreasing. I will say that what is most important here is that we're able to compare ourselves to other places, no matter what those populations are. So we have 93,000 people. Chicago has a couple million. What we do in order to standardize that number is that we multiply it times 100,000. So we say that those 5 mean 5 people in Fishers had it in one day, 5 people in Chicago had it in one day. But if we multiply our all of that information, that case rate for our area times 100,000, I can compare myself in Fishers to Chicago. It'll be an apples to apples comparison, because we're talking about the number of cases per 100,000. So that's important for us to take into account when we're looking at what our city and our disease looks like. So I wanted to set this stage because these 2 metrics are important, but so are the world in which they live. So if we, the second point there, public health capacity, if we are testing well, if we are able to get our test results turned around really quickly, and if we are able to trace those contacts quickly, then those metrics are a great way to measure things. If we start to have delays like we currently have, where we don't have enough testing turnarounds are delayed, we don't have enough reagents, we don't have enough contact tracing to keep up, you'll start to see that it's harder to identify and isolate these folks. And that's when we start moving into those yellow, orange, red zones. The other thing we need to take into account here is also our healthcare system capacity. We have some amazing hospitals and healthcare in this state. We actually have some of the most ICU beds per capita in our state compared to other states. We have a lot of room in hospitals, but it's important to note when we start seeing that decrease. That's an indicator, but it's a lagging indicator of disease in our area. So I want to make sure we take all of this into account as we look forward to showing our risk as a community and making activities dependent upon where we as a community stand during this pandemic. And that also includes schools. So we will have information on our website up about this. It will be color-coded. We will set the level for our community at any given time. You can go on and reference that. That will help you make decisions for both your community activities and your school activities. And to that end, I'm going to turn it over to Indy, who's going to talk some about the community mitigation strategies. Keeping this in mind.
Before we move on, does anybody have any questions?
Sorry, that's a lot.
Okay.
Yeah.
I don't like the comparison to Chicago because our density is substantially less, right? So if we compare to a city that's spread out like we are, I think it would be more applicable.
So when I mentioned comparisons, I'm trying to compare a number of people standardized in each area. So the density is true, that's a factor to keep in mind.
Right.
But it could also be Walkerton, it could be Michigan, I mean, pick your place. It needs to be a consistent comparator.
I think it's important. She was giving you a hypothetical
Right.
of Chicago. We're not coming in every day and going, where are we at next to LA and Chicago?
Right.
It was just an example of your ability to universally compare yourself against anyone based on per capita.
As you look at the levels that are listed, is this a situation where you might start saying, hey, Fishers, we're in a level 2 right now, and then as you make that determination, is it based on the worst case? So we may be level 1 in community transmission and healthcare capacity, but we're level 3 in public health capacity. So we're level 3, or can you help me understand that a little bit?
May I take that? So I think the important thing to note about this is that we're not using one metric because we have to take all those things into consideration, right? So I would say that right now, if we're gonna pick a color right now, we're on the border between yellow and orange. We're in the yellow, but at this point, it appears that we're heading closer to orange. And that's a lot of reasons. Some of our measures here are in green. We have our testing delay heading into red. So we look at where are they most lighting up, right? But if we can't meet the community needs, if we can't get everybody contact traced, which right now we can, contact tracing is in the green, but as far as our local situation goes, the state situation is also a factor, so we might move them to a different level. So we're not even just looking at one metric for percent positivity. So just to put that in context too, we're looking at our testing site percent positivity, we're looking at our county positivity, we're looking at our state positivity, because we don't live in our Fishers bubble all the time, right? We have kids that are participating in things that are in Noblesville and in Indianapolis and that kind of stuff. So we can't kind of hang our hat on one specific measure. What we're saying here is that our primary consideration, the first thing we're going to look at is these two rates. But we have to take them in context of these other factors. And these other factors are considerations. If our hospitals are full to overflowing and our rate is low, then that's going to affect some other decisions that we need to make. We need to be able to flatten the curve like we did back in March and April to keep the hospitals from going over capacity, because that directly relates to mortality. So all of this is interrelated and it all affects each other. So having to hang your hat on one measure is just not feasible. I know that Dr. Box brought this point up as well yesterday in a webinar that she had with local health departments, as well as on the governor's the weekly press conference that they do on Wednesdays. And that's why the state hasn't produced any specific metrics for schools or for other things. And that's why we don't just say one metric, right? We're trying to craft a way for us to project to the community where we're at and what your risk level is based on these wide variety of considerations.
I think also, Clint, one question that I had when they proposed this, and I'm sure you guys were thinking about it, this isn't going to be every morning, let's tune in and see if the color changed dramatically from one way or the other, because we understand the policy implications for these colors changing. So, for us to come in to you on a Monday and say, well, it's green, and then on a Wednesday say it's red, that has dire implications for our community. And with all these variables that we're looking at, the likelihood that you're going to see some wide variation one way or another is not very likely, and we hope that does not occur, certainly to the negative. And you'd be foolishly optimistic, absent a vaccine, that all of a sudden it's just going to fly to, well, we have literally no cases ever again in the city of Fishers. So I think, this isn't going to be a every day, hold your breath, let's see whether kids can go to school conversation whatsoever.
Yeah, I would anticipate that we wouldn't be changing colors more than every several weeks, and we would be giving heads up through our daily videos or whatever, saying, we're solidly in yellow, and we've been here for a good long time, this is great. Or like right now, we're yellow, but we're pretty close to orange, so we may be moving to orange soon, right?
What has been the trend over the last 60 days for these metrics for the city of Fishers, and where would you assess Hamilton County, and where would you assess the state of Indiana?
So I would say 60 days ago, that would be early June. We were probably in yellow heading into green, because in the middle of June to late June, we were feeling really good, right? Everything was looking great. Our percent positivity was under 5%. We weren't getting very many cases every day. We had great testing turnarounds. We were able to jump on all the cases that we got right away. The hospitals were emptying out. They were getting towards emptying out, and that again lags behind all the rest of these. And the hospitalization rates were decreasing, right? So when we started seeing that uptake around 4th of July, we started looking really carefully at these things. And the first thing that we saw was that our case numbers were increasing, right? After that, we saw that our percent positivity was increasing. After that, so we have these early indicators, which is why that's our primary metric that we're considering, because those are the first signs, right? That things are starting to move in a certain direction versus another direction. So when we started seeing those indicators and those things kept building, that's when we started making plans to put a mask mandate in place, because we knew it was coming. And what did we want to do? We wanted to support the schools, we wanted to support the community, support the businesses, and say, we think we can still do this. We can still get a handle on this, and we're here. We just need to put some extra measures in place, so we start with the things that make the most sense, that are the least restrictive. So that was the rationale behind the mask mandate, was saying, let's do what we can. That's the easy step to try to support all these other things that are around it, so that we can continue to move forward.
Where is Hamilton County on this scale?
They would be in the same boat. The percent positivity for Hamilton County yesterday, according to the state website, I believe was 6.9%. Our local testing site is a little bit lower right now, which is great. Our Fishers, we can't get the exact number for Fishers on a percent positivity, because those numbers are reported only to the state. We're working on it. We may be able to, but we haven't been given the green light yet for that. So that's why we're taking all of these things together. But even if we had just the Fishers data, it wouldn't be the only metric. The case incidence on Hamilton County and on Fishers is running into the low orange area. So we're right there with the rest of Hamilton County.
Okay, if the new cases are the primary problem, can we stop sending the samples to the East Coast and taking 7 to 10 days, and maybe do what Riverview's doing and getting the results in 2 days?
So let me,
Right?
Riverview has stopped providing tests to anyone who's asymptomatic because their capacity is pegged. We're not sending our tests to the East Coast. They're sent to the Midwest, to Chicago, and also to a local lab. So the delay isn't driving to the East Coast. The delay is that nationally, because of in the South, we saw huge spikes, and there's tremendous demand in Florida, Texas, Arizona, and really across the country, that we're seeing people testing in unbelievable amounts, plus society turned back on. So surgeries, elective surgeries, now everyone needs to get a test before they have an elective surgery, kids going back to universities, all of that is really the factor here. The location of our testing site and where the lab services go is not the issue at hand.
Well,
Mrs. Pritchett,
hospitals as well.
Yeah, Mrs. Pritchett and I can attest that our kids are getting tested to go back to Purdue. They're testing every kid that steps foot on campus. You have someone watch you do the swab. They say, get it to UPS in 2 hours. My kid got his test result back in 2 days.
Right, but those tests aren't as reliable as the tests that we're using in hospitals and the tests that we're using at the Fishers testing site. So for low-risk populations, where you want a quick test, that's reasonable. That's not the best, those aren't the best tests, and we have other considerations to take into account. Because of the acuity and the turnaround time in Community Health Network, we have moved to you have to be symptomatic or very sick to get a test now, and people that need surgery, instead of them being able to get the traditional test, now we're doing a saliva test, which
Right.
is suboptimal, but with the shortages, at least it's better than not testing them at all. So,
to your point, Amanda, we are almost on a daily basis talking to the labs to identify how to increase capacity so that we're improving the turnaround times. Like, it's very frustrating to us. It's very frustrating to me as a policy person to sit here and have to make decisions on whether people can get back to their lives simply based on a logistics issue.
Right.
I mean, that's very frustrating for all Americans, I think, is, because we can't get a test done, somehow that changes or might influence this color code, which then has serious implications on how a family lives their life, you know, that is very frustrating. And so we are working on a daily basis to identify increased lab capacity so that we don't have those issues. So it's a very good point.
Are you considering going to the saliva test that like the universities are using? That's a quicker turnaround. Because that would give us better information for young people who are, right?
Well, MACL needs to be able to provide that test. I'm not sure if at this time we're not using MACL for that at the hospital until, you know, I know that the mayor has been in contact as well as Monica with MACL. So I think that it's a matter of availability of the test and being able to do the test at the number of tests that we need on a daily basis.
Because they're using Spectrum, right? Spectrum.
What we have, what we've identified with, so in maintaining the integrity of our tests and the accuracy of the test is important, I think, for us. Secondly, in our conversations with MACL, really up until this recent steep increase, we were seeing 72-hour turnarounds fairly consistently. It's really been over the last 3.5 weeks where we've seen this big spike. In my conversations with the CEO of MACL, they have another device that's coming online in the next 2 weeks locally that should increase their capacity significantly. And because Fishers was one of their first significant clients to come on board, I believe that we're going to be given a significant priority to be at the head of the line when that lab comes online. So we're very optimistic that we will be able to see increased improvement in turnaround times in the next week to 2 weeks.
Thank you. Thank you.
Can I ask clarity on what tests we're doing and its accuracy? You referenced accuracy, and what kind of, and compare those different testing, please.
Right. So
what is it testing for?
So what we're doing is a nasal swab that actually looks at genetic material for the virus, which is considered to be more sensitive than, you know, a saliva test, or at this point, to my knowledge, there isn't a blood test for the virus. It's mainly cultures. So that's what we're using. That's what, you know, most hospital systems consider to be the standard of care. There are some what we call point of care tests that are done that have a faster turnaround. If the test is positive, we consider it a true positive. If the test is negative, however, and you're still highly concerned that the patient or the individual has COVID, you would send one of the nasal or nasopharyngeal swabs that we are doing at the Fishers testing site, or that are, you know, more commonly done. So the point of care testing, the saliva testing, we don't have the same level of confidence with that we do with the nasal swab or the nasopharyngeal swabs.
And what is this accuracy rate? And what is it, you're saying genetic, and aren't there a lot of genetic-like similarities even between flu viruses and this? How would we know how accurate that is
I'm
for
sorry,
COVID?
what kind of viruses? It's a reverse transcriptase test. You know, and again, it looks at the DNA. It matches genetic codes for the virus with the test. I'm not sure if I understood the second part of your question.
Well, it just seems like that is, from what little I've read, is that there are similarities amongst the virus particles that it could be misinterpreted to be COVID versus another virus.
I can't personally speak to that. I do, you know, when you have the test, whether it's positive or negative, obviously depends on where you are in terms of the infection. So is it very, very early? Is it much, much later in the process? So that's important as well. In terms of whether or not the test is positive or negative. If a patient has, or an individual has a negative test, but they are highly symptomatic, we still, or they have an x-ray that is consistent, that has that ground glass appearance, is consistent with COVID, we treat them like COVID patients. So, you know, even with the more traditional reverse transcriptase test, it's not perfect. You know, it's not 100%, very few tests are. Same thing with the flu. You know, we have to use, just like with our scale here, we have to use different factors to, you know, paint the true picture.
I think for the purposes of our conversation with all of you today, we believe and will continue to believe that testing is a key component of a community or a city or a country's ability to mitigate pandemic to identify those individuals that are sick. We believe that we are using one of the most accurate tests available on the market. We're going to work very hard to improve the supply chain so that we can improve the turnaround times. But all this being said, it just plays into the broader conversation that I think Dr. Lane and her team is conveying, which is it's one part of a broader conversation about how we come to these decisions about where we're at as a community. And so I think what's important is that we're not hanging our hat on one specific number. We're looking at the totality of the situation in our community and trying to make a determination. Dr. Lane, you want to share from a community perspective what these risks look like?
Yeah, so I think that as a health department, we wanted to speak to what we've heard from the community, that they are very appreciative. Everyone's appreciative of the dashboard. It's a lot of really good information. I think that we feel confident in the data that's being presented. But what does this mean to the residents of Fishers on a day-to-day basis? And as Eileen alluded to, we want to be able to use some guidelines to give you an overall picture on every few weeks where we are as a community. And so I won't read all of these things to you in the interest of time, but what we've done is we've assigned a community risk level based on whether an individual is high risk, and you can see the high risk conditions and compared to people that are low risk, and then how that relates to businesses in our city and how they can go about doing their day-to-day business. And so you can look at the different categories. I feel compelled, Sal Monica this morning is OBGYN. You can see under high risk individuals, particularly with the school system and young female teachers or employees. Pregnancy is not on that list. However, a pregnant patient with one of those high risk conditions may be in a high risk category as a result. And so I think that we feel very comfortable in saying that pregnant women can get the virus. We have not seen the same severity with COVID that we see with the flu. For instance, flu in pregnant women can be extremely dangerous. We always recommend vaccination for pregnant women. We have not seen that with COVID. We have not seen vertical transmission or transmission to the fetus, which is important. Newborns have been able to get COVID, so it is important that everyone wear a mask at this stage of our level of activity and use frequent hand washing and that sort of thing. So your pregnant employees can work safely. I would ask that you accommodate them in terms of masks and social distancing and that sort of thing, and facilitating all the other things in terms of hand washing and hygiene. And so you guys can obviously take a look at the risk assessment, and as Monica and Eileen said, we'll have a color associated with the city of Fishers based on these risks. And you can, based on the color, for instance, if you're a low-risk person, again, consider limiting your large gatherings when you especially can't social distance. You want to wear masks. And just frequent local establishments that allow for the appropriate social distancing and safety. So you can read through that, and that will be on the website as well. And again, we'll associate a color each day. It won't change every day, but you'll be able to go on the website, and I feel as though residents will be able to have a clear way to determine how they go about their day-to-day activities within our community.
I think this is a good point to say these are guidelines. This is not so just from a legality perspective, this is not a public health order. So if we say, if Susie, who has COPD and wakes up in the morning and goes onto our website and all she gets to look at is that dashboard and that trend line, unless you're Eileen or Monica or Indy who geeks out on this data, you look at that and you're like, I don't know what that means. It's gone down a couple days. Does that mean I'm safe to go outside without a mask? Does it mean I can go to a restaurant? What we're trying to provide is interpretation of the data and everything else around it to be able to give people almost a forecast, if you will. It's the equivalent of saying it's going to storm today, grab an umbrella. And that's really what we're trying to do here. These are guidelines that we're trying to provide to the community in a very consumable fashion.
And I think Eileen alluded to, the green does not mean the risk is zero. And I think it's important. We are all hoping to get to green, but until we have a vaccine, we will still have to be careful. It will not mean that we have no COVID in our community. It means that we have less COVID, and we are able to test people appropriately and isolate them so that we can limit the spread and mitigate the risk in our community. You have anything to add?
No, that was beautiful.
Okay, and with that, I'll hand it over to Monica. I think that she's got the information you're probably most interested in today.
Okay, so this is why we're here, right? The school recommendations. So I want to first highlight these risk levels and the labels that are on them with low, moderate, significant, and severe risk. We are not implying that that is your individual risk. This is like a community. Are we as a community able to handle this kind of a risk? This is a community level risk. What we see with the trends, when things start going up, they start doing that, and then they hit exponential levels. So this is the reason why we kind of ramp up pretty seriously between orange and red, okay? Because once it gets over a certain point, then we start to see exponential increases and it becomes completely uncontrollable. But those labels, again, have to do with community risk, not individual risk, okay? So when we're looking at the schools, we kind of wanted to take some of this contextual and metric guesswork out, because that's not, you guys shouldn't have to worry about that. You should worry about how you're going to educate these kids. This is your expertise. Let us try to figure out what risk level the community is at. So that's why under the school assessment considerations, we're saying first look at where we're at as a community. Are we at green, yellow, orange, red? So this is factor number one, right? Then the schools are going to have to look at the other contextual factors within the schools, right? As far as the community might be at a yellow, but if the schools are having multiple classes, quarantining, difficulty managing contacts with the quarantines, and the half the teachers aren't coming or half the bus drivers aren't coming, they can't support all of the school activities, then the school might be in orange. The school might need to be in a different kind of stage when they consider all of those factors. And that can be considered on a grade level, it can be considered on a section of a school level, it can be considered on a school level or on a district level, right? So you could have one school that is unable to function because, let's say there have been too many classes quarantining in that one school, and you may have to say, we cannot support in-person learning for this school, but the rest of the district might be fine, right? So making that determination just based on a community level is not realistic, right? So what we want to do is try to figure out how can we support you guys in every way that we can from a public health perspective to make it safe to go back to school, to assure the safety of the kids, to assure the safety of the teachers. And I want to highlight that we really think this can be done. We think that we can have kids in school. We think that we can do it safely. But there's all these other things to take into account. So it assumes if we're going to have the kids in school, if we're going to do this safely, we've got to take into consideration all of these other factors, and we've got to have really great mitigation measures in place. So those mitigation measures are that second step, right? So a lot of these, they should not be new. A lot of them were in the CDC plans. They were in the State Department of Health and IDOE guidelines. There are things that I've suggested in meeting with you guys, and a lot of these are already in your plans, right? So a lot of this has already been incorporated. So for example, the cohorting of classes, that's a big one from a public health perspective. Cohorting of classes means keeping the kids together all day. Elementary schools are already positioned to do this. They already have kids in the same class all day, right? They're not switching classes every hour. Middle school and high school, when you get to the junior highs and the high schools, that's a really important factor in our ability to respond and in the school's ability to respond to positive cases. Because the more kids that you have exposing themselves to each other, the faster that's going to spiral out of control and the more chance that we're not going to be able to control it in that setting. So cohorting is very important from a risk mitigation level, okay? So I just want to highlight that because that's probably one of the single most important things we can do. The other single most important thing we can do is wear masks. So again, part of the rationale for the mask mandate was to help support you guys, to help support our community, to get these kids back in school. And masks, although not perfect, I know there's a lot of talk about that, they are certainly better than nothing and extremely effective, really, over large community data sets at preventing ongoing spread. So we know that in situations where people are wearing masks regularly, the spread significantly decreases. Are some masks better than others? Yes. You know, is a surgical mask better than a cloth mask? Yes. Do we have the resources for everybody to have a surgical mask? Probably not, right? You know, we still have some shortages on the national level. You know, we can get them better than we could in March, but we're recommending cloth masks because for the average person that should be sufficient. If we're all wearing them, we're not going to transmit broadly like we do without wearing masks.
May I ask a question?
Uh-huh.
Do you foresee, based on the trending, that we will go the entire school year with masks?
Impossible to predict.
I think it's a bit early to predict that, but at least from what we know now about the virus, masks are one of the single best tools that we can use to help us decrease the spread in settings where we're around other people.
I think anybody predicting anything in 2020 beyond 4 weeks, you know, good luck. I think what we're trying to do here, and again, I think what this matrix allows us to do is we can adapt and we can evolve, but we can all speak with a common language. So if we're saying, hey, we're in yellow today, but we're having some challenges here, we can keep an open dialogue with everyone so we know we can anticipate together if we have to make a transition, we know what that transition looks like. You know, we got to go from being clumsy in these interactions to being collective in these interactions. And I think what Monica is articulating here with the schools, so let's say today hypothetically that, or practically we're in level yellow. If we are, here are what we believe are the most prudent and rational ways to reopen school that's safe. This is your ceiling, if you will. These are the things that we think can be accomplished under the current conditions within our city. If those colors change because the context within our community changes, then that ceiling lowers or heightens depending upon the situation. That's really what we're trying to do here. Now, to Monica's point earlier, we don't run the schools and we don't understand the intricacies of the operations. And so what we did is try to paint broad brush strokes of, here are some things that could be accomplished, but Dr. Borf and his team, they may say, hey, you know what, that's great, but we're going to have to do it slightly different because it just doesn't fit our operational model or there's staffing challenges we're having. We're not here to cast judgment or make comments on those because we don't know those. All we're saying is from a public health perspective, if these things were to be accomplished, it's the ideal situation given the context that we find ourselves in our city.
Yeah, and to that point, just moving on to the recommendations, I wanted to just highlight a couple of things. Like for example, right now, if elementary schools were to be open, it would be really important that these other mitigation measures were in place, right? You would have to make sure that you're cleaning everything. You would want to take everything outdoors as much as possible. I mean, having 25 kids in a classroom, it's a congregate setting, and, you know, we're not going to say that it's not. Wearing masks is important, you know, and our mask mandate is for 5 and up, not 8 and up like the states, and part of the reason is to support the idea that we can get those kids in class safely if they wear masks, okay?
Can I ask a question about the risk to adults in those situations? Because a lot of times when we're looking at this, I'm thinking students. Like we're looking at how many students are in a classroom, how many students are in a cohort, but what, you know, and especially in elementary settings, I would say, you know, older grades, you have a lot of teachers that may be able to distance themselves pretty adequately because that's kind of the nature of the job. But for elementary students where someone needs a hug or someone needs some instant, you come over, look over their shoulder on your, so what does that distancing, how does that change, or does it, this model for the adults in our corporation?
Do you want to take that, Andy, or do you want me to take that?
So, you know, I think that it's important, the masks are important for the younger kids because, you know, thankfully kids do not appear to be getting as sick. as older kids, but also keep in mind its duration. So if you have to come over of contact, so, have you been within 6 feet for longer than 15 minutes with that student? So it's not just the proximity, but it's also the amount of time. So if you have, a 7-year-old that needs some additional attention and you have to get, provided that both the student and the teacher has a mask, it is safe to interact with that patient and provide the emotional support that the student needs. So we want you to maintain a safe social distance when you're indoors and everybody's still kind of sharing the same air. Ventilation can be an issue. We want to be sensitive to that, but I don't think that any of us are suggesting that there aren't going to be times where you need to get closer to an individual. We just want you to be mindful of the duration, okay? And leaning over the shoulder is different than, being right in their face as well. So just kind of those common sense sort of guidelines. We know how important that interaction with the student and the teacher is on a day-to-day basis.
Yeah, I think you bring up a good point, and maybe Monica or any of you can speak to this. We have talked a lot this morning about the risk profile to our children as they go back, but we're all very big supporters and champions of our teaching community here. Our teachers are incredible individuals. I know there's a lot of anxiety with teachers as they contemplate coming back into the classroom. There's a lot of mixed emotions, and that weighs heavily on our discussion about what is in the public health interest and what is safe for our community to do. So maybe, Monica, you could talk a little bit about, as we developed this, we developed it from a complete risk profile. So it's not just the kids, but it's also those teachers in the classroom. And maybe talk a little bit about that or address that for the teaching community that might be listening to this conversation today.
Yeah, so when we talk about risk, we talk about it in two ways. We talk about not just the risk of the person who could potentially become affected, but the person who could potentially infect them, right? So one of the things that we know that little kids can transmit the virus. That's not a question, but are they going to transmit it as efficiently as a teenager or as an adult? Well, the studies would suggest that kids under 10 are less efficient transmitters than kids over 10, okay? So that doesn't mean that anybody is at a no-risk profile. None of us are here in this community. If we want to be out and with any other person, then we're gonna have to accept some level of risk, okay? But we know that we can do this safely. We've seen the daycares operating through this entire thing. Have they had cases? Yes. Have they had to close at times? Yes. Have they had situations that we've been troubleshooting? Yes. But have we had any serious consequences from that here locally? Not really. We can do this, and we do this by putting these measures in place. So we know that the littler kids are going to be less efficient transmitters. That's a function of their lung capacity. That's a function of their closeness to the ground because things fall through gravity, right? That's a function of a lot of different factors. If they cough, they're not going to cough quite as vigorously and be able to expel the particles quite as far as the older kids, right? So we think that the younger kids pose a smaller risk from a public health perspective than the older kids. I'm very concerned about the junior high and high schoolers, partly because of the structure of junior high and high school, which is why we strongly recommend cohorting, because that mixing every hour is problematic, right? So the measures the recommendations that we've made are different for elementary school than they are for middle school for those reasons, okay? But can it be done safely? Yes. But we have to have all these other things in place. We've got to support the teachers with taking the appropriate mitigation steps, having the appropriate plans in place. And the teachers can support us too by having assigned seating that will decrease the number of kids that will have to quarantine when somebody does come up positive. I know with the current plans right now, with the 50-50 hybrid plan, I believe that, I just want to speak to this because that has public health implications too. So with the current 50-50 plan, with having the kids come in Mondays and Wednesdays or Tuesdays and Thursdays, I think that was how it went, right? And then Fridays were off. From a public health perspective, that is, I understand from an educational perspective that probably makes sense, but from a public health perspective, it doesn't make a whole lot of sense. Because if you have a kid who's exposed on Monday and they come back on Wednesday, they may not have started exhibiting symptoms yet. Let's say their symptoms start on Thursday, then all of the kids they were around on Wednesday would then have to be quarantined. If, however, you did a 50-50 on a Monday, Tuesday, and a Thursday, Friday, you could use Wednesday to clean. And then the kids who were exposed on Monday and Tuesday would have a full week to figure out if they're developing symptoms. When we look at contact tracing, we go 2 days before the symptoms start. Symptoms usually start after 2 days. Sometimes they start that soon, but usually it's out further. We would have to quarantine less kids, basically, is how that function works. Does it mean that kids weren't? Does it mean that no kids were exposed? No, we're going to have cases. We're going to have contact investigations. We're going to have to deal with this. But can we look at ways to mitigate the impact? Yes, absolutely. You know, by taking just a few tweaks to what we're doing and a few extra steps, we can bring these kids back. We can do it safely and do it smartly.
So I think there's a good transition point here, and then hopefully we can open up to any questions you might have in general. And that is, you know, just like for us, when our response to public health issues around COVID was, okay, let's get the health department up, and then we got to do chapter 2 and chapter 3. For me, as I look at the school system, getting our kids back in the classroom is the definition of success safely. Secondly is we have to be able to respond when someone gets sick well. And we have to do that coordinated so that, you know, President Fullhart, you were in a tabletop with us where we worked through some of those challenges, and we have to continue to get better at, you know, Susie pops positive for COVID in Cumberland Road Elementary. How are we going to deal with that so that we have the least disruption to everyone while keeping everybody as safe as humanly possible? I mean, those are our definitions of success. So for our health department, we stand ready, to provide guidance and educated and informed guidance around what the context for we find our city and what, you know, we view as an appropriate or reasonable risk level. But then we also stand ready to respond with you as we try to figure this out. We stand ready to work with you to ensure that we have the resiliency in our school system and that we're keeping our kids and our teachers safe as we open up school.
So when you, like say we're in level 2, we're just talking about cohorting of all classes. I think, can you just clarify your definition of cohorting? Would you mean like the class stays together all day for lunch, they have lunch in their classroom, they're not mixing with any other classes? I just want, we may have different ideas.
So the groups stay together, right? So this is a kind of a similar model to what the elementary school kids have. And even the intermediate school has this, you know, and I don't know if all the different intermediate schools are run differently, but, you know, they have just 2 teachers, but the class is actually the same class that's sharing those 2 teachers, right? So those kids are cohorted, okay? Additional cohorting measures can be if they have a small group, let's say, that they're always assigned with, you know, and so there's a lot of ways to do cohorting, but it's keeping the same kids together throughout the day instead of mixing them up all the time.
So you would interpret that as being like they would eat lunch together, say in their classroom, as opposed to going to the cafeteria and having lunch with lots of different classes? They can
cohort in any place they're at, right? Ideally, they're not going all over the school.
But you wouldn't mix those cohorts.
You wouldn't mix the cohorts, so
lunch, things like that, like how.
So you can take the group to lunch together, and they can go to recess together. So it's not about where they're at. It's about where they're with each other.
Well, when we're talking about like lunch, for example, we may have like 5 cohorts in the cafeteria.
Yeah, they need to be separated.
Does that defeat the purpose?
They should be staying with their cohort at lunch.
Okay.
So they can have 5 classes in the cafeteria. Not ideal. I would prefer them to be spread out in the outdoors in the gym and like as much spacing as possible. But keep those classes together. Staggering passing periods, not having them all in the hallway at the same time.
But I think that if they can't do that in the gym or the cafeteria, if eating in the room keeps them together, I think
to minimize that
a reasonable approach.
And I think, again, our goal is these are principles or concepts that you guys need to interpret into how you operate. So cohorting, in the best case scenario, every kid would be next to the same kid in perpetuity for the year. We understand We understand, right? We live in a logical world. That's not going to happen. But there are things that you can do to try to get closer to that concept than where we are today. That's what these guidelines are. And that's where, I mean, unfortunately, I would say this to Dr. Bohr from the team, that's where they have to figure that out. That's not for us to try to
And that's
prescribe.
fair, I just want to make sure we understand what your idea of this is, so that we can kind of then bring that
Yeah, for
into
sure.
what we can do here.
Yep.
We want you to get in the weeds with us.
Yeah.
What I heard on a national level from Deborah Burks, who I'm now in her fan club, is let's come on. I have a daughter named Deborah, so is that if you can keep the kids in the classroom, have lunch delivered on a cart, those kids are all together. Bring the music teacher, bring the art teacher.
And that was suggested in the CDC guidelines, it's not,
Yes.
you know.
But boy, that would nip it in the tail, right?
If you're able, but every school, I would imagine, again, I'm not an administrator, is unique, right? And maybe that doesn't work for every school. So I think, again, to the mayor's point, you all are the experts in terms of schools, and you have to look at each individual school and determine which of these measures makes the most sense and that you have the resources to support. But you're absolutely right, and that gets down to, as a public health person, they love that cohorting. The teachers moving around, that makes everybody very happy. But we also recognize that everybody has a unique situation in terms of their school. And that's where this provides you with a framework, and you guys have to tailor it based on the needs of your school.
Could you talk to us a little bit about extracurricular events? And I notice it's listed just in level 1. Is it your thought that if we're not in level 1, we shouldn't be having?
No, the thought was that I was running out of room at the bottom, but I think the IHSAA guidelines are very good. And the athletic department particularly, I haven't had a lot of conversation with the music and band and that kind of thing, but the guidelines are very good. And they've been able to follow those guidelines pretty effectively. So we've seen a lot of this already play out in our athletic teams and some other groups as well. And the ability to respond effectively is really critical, and they've done that, and they've done that effectively. And the other thing that I would say, because they use the IHSA guidelines really well with keeping the practices in smaller groups, minimizing that contact aspect of the sporting events, taking those extra measures, spreading the kids out when they're in the weight room, wiping things down a lot more thoroughly. All of those extra measures that they have taken that are in the IHSAA guidelines have really prevented a lot of spread in those activities. Okay, so it is very successful. What we have found is that most of the spread that has happened with the kids in the activities has happened outside of the activity. And we know that that's going to happen, and that's why these extra mitigation measures are in place and why our response plans are important, right? We're not immune from the rest of the world. The kids are still going to be getting together in some level. But as far as the measures that have been taken, like I said, the athletics department has done a great job of really taking to heart those IHSAA guidelines. The guidelines are good, and they've implemented them, and that has saved a lot of trouble. We've had trouble, but we haven't had the trouble like we would have if they hadn't taken
Well, and I think
that.
to that point, those activities are continuing on even though we did have exposures and we did have people sick, but we worked well with the school system and we identified those individuals and we worked through that, and we're only going to get better at addressing those issues. And so I think it's a great proof of concept of what we can do around the schools. This is going to be trial and error. We're going to have to get into it. We're going to have to learn how to work through these things, and some things may make sense and other things might get thrown out the window because they just didn't work. But we stand ready to help you guys in any way, shape, or form. We now entertain any questions from any of you.
I have a question about, we didn't really touch on this, but just kind of a logistical thing that just keeps coming up for me is when we're talking about symptoms and we're talking about, we may have a list of symptoms that we don't want to send our kids to school if they have, and there may be 5, 10, I don't know, however. What would be the recommendation on who would, so you have a parent that might assess their child, let's say they have asthma and they have some breathing issues, maybe it's high asthma day that may not have been yesterday. How do parents, and then adversely also on the school side, how do they know what symptoms are, yes, let's go, no, we're gonna stay home? How do they discern that? And who does that? Obviously the parents first, but then if they call and say, or they arrive at school and the asthmatic child, truly, they're just having asthma symptoms. How does a teacher not think, oh my gosh, there's breathing, there's coughing, I don't know what this is? How?
It's hard. We struggle with that, as well, because everyone was, afraid to come to the hospital for a long time, and then we assumed everything was COVID, and we had to, as physicians, we had to take a step back and say every cough isn't COVID, right? Every episode of shortness of breath isn't COVID, and so the same process has to take place with the child. I would say there are multiple symptoms. If a child has a fever, just like before COVID, the child probably should not come to school. Right. If the child has asthma and is coughing, I think that the parent has to assess that, that child in terms of, this is what I typically, or the parent typically sees with an asthma exacerbation, and contact the healthcare provider. I think that we're approaching flu season. There are going to be lots of respiratory illnesses that are approaching us in the fall, and we have to, be on high alert because, COVID is a concern, but there are other respiratory illnesses that we need to be concerned about too. Interestingly enough, we're not seeing the flu in the southern hemisphere like we typically do because everyone's wearing masks.
Yes.
So I do think that
it's going to help everything.
Right, I do think that we are typically very, very worried about flu. We usually modify hospital visitation because of the flu season, so I think the masks are going to help. But I think that the parents, for right or for wrong, are going to have to use their best judgment and probably be a little bit more hyper-vigilant in terms of calling the child's provider, keeping them home from school until you can be certain that it's not something, more worrisome.
And I want to tag on to that too, that the kids tend to have more mild symptoms, so it is going to be extremely hard for people to sort that out. And anytime somebody can use more caution, that's going to be supported because for example, allergy season is now. We have a lot of people that thought they were having allergy symptoms and they turned out to have COVID. Okay, so
allergy, like my eyes are running and
so it can be very difficult to sort out because a lot of, it could be a runny nose in a kid, and so that's why the screening questions are important and that extra support from the families are important, and not pushing their kids out just, because it's inconvenient for them to stay home is important. We need the whole support of the community to be on board with this and to say, we're going to take our responsibility. If my kid has the sniffles, maybe we should keep him home today. If we can't, we're going to have to figure this out, right? And we're all going to have to be extra flexible, and we've all shown that we can be because this year has taught us nothing if not that.
And diarrhea, too. GI symptoms are something else that kids will sometimes present.
Hopefully nobody's coming to school with that anyway.
I just figured I wouldn't say it out loud.
So I'm looking at the 11 symptoms of COVID-19 on the Indiana Department of Health website. Pretty much everyone, my children have not stayed home from school with anything other than what's on here. So a question, I know fever, our policy has been 24-hour fever-free and you can return to school. How would we need, in light of coronavirus, how would our policies need to change on that?
Those guidelines are very specific for schools, and they're on the State Department of Health website. I know that Kelly is very familiar with them, and I think the school's been working on building them into the policies. But if you can't rule it out with another condition via a healthcare provider note of some kind, then really they shouldn't be going to school until they've met the isolation guidelines with presumptive COVID. So the 10 days fever free for the last 24 hours and symptoms improving.
Okay, and in an ideal world, if our testing capacity was where we would like it to be, would you recommend if a child has any of these symptoms that they be tested prior to returning to school?
I would recommend testing in general if you have a suspicion for COVID, because that allows us to do the contact investigation and take this out a notch. It doesn't affect if they can come to school any sooner.
I
Okay,
think this
unless you have that healthcare provider note.
This is
that
one of the
says
things
even
that
though-
President Fullhart, I get tripped up on. I have a hard time swallowing this pill because Monica and I have this conversation all the time. Someone thinks they might have COVID or they're presumptive they have symptoms. It would seem logical, well, if you go get a test and it's negative and you no longer have the symptoms, you can go back to work. And I struggled with this mightily for a long time. And then, you know, I'm not the brightest individual, so finally I figured out there's an incubation period where you could go take that test and not show up, but then 3 days later it could. And so, you know, this sitting out waiting period is really nothing more than to identify whether or not you do present finally with it. And so the test, to Monica's point, I think this is, I'm glad you brought this up because I think this is a really good clarifying point for people because we deal with this even with our employees. The test is for us to identify you if you do indeed have COVID so that we can go address anybody else and isolate you, mitigate any issues that might occur with anybody else, but you're still going to have to sit out for that time period. And, you know, that's unfortunate. It has ramifications, frankly, for your employees as well, right? So a teacher gets a fever, you're going to be dealing with an extended period of time not in the classroom. Regardless of whether I had a test there tomorrow for you to go get tested, you're gonna have an extended period of time where that teacher's not in the classroom.
Now, they could return with a negative test and a doctor's note, or with just a doctor's note that says this is not COVID. That, you know, they can return before the 10 days with that. Supporting that
Because there's confirmation then that it's not.
Because you've
You might
got
have strep
somebody
throat or
who's
something.
made that assessment that says, I feel confident this is not COVID, you go back home.
But it's more convenient to have one teacher out for 10 days than have to shut a school down because we have
For sure.
a bunch of
Yeah.
positives.
Right.
So maybe we can encourage the community to
Agreed.
understand keeping their kid home. It's inconvenient, but it's easier than having to close.
That's kind of the contract, right? Like, if you guys help us be able to do this, then we can have school. If you are derelict in your duties, then there's a chance that we're going to have to start closing buildings down, and then, you know, it's going to be really problematic for everyone. So yeah, absolutely. And I think we as a public health department need to help spread that message to really reinforce that.
And that's what we talked about on July 20th, when you said, let's just wear the mask, let's hunker down, let's see how this looks in 4 weeks. So are we looking better? Can we tell yet if it's helping? It's been 18 days?
So,
How many days?
I think it's too early to do like a full
Okay.
assessment, but we know it's helping, right? I mean, the numbers aren't supporting it helping yet, because we're still in this larger context where things are going up. We're starting to see deaths increase, we're starting to see hospitalizations. We're not seeing deaths increase locally, but that's a lagging indicator. That's gonna happen when we're back on the downswing, you know? All of these things are contextual. So we know that it's helping because we know it helps. But do we have the numbers to support it yet? No.
Well, and success may very much look like a plateau. You know, we opened society back in the June timeframe, late June. It's logical to think that when everyone was closed and everyone was sitting at home and no one was doing anything, that the number of cases was going to be somewhere here. We opened society back up and cases started going up. The definition of success for me isn't necessarily that we're going to push it all the way back down to where it was when everyone literally never left their basement. But the key is we don't see a hockey stick growth where it just exponentially continues. And so, you know, we may not know, but these masks may have prevented that hockey stick growth, which allows society to continue to be open. I mean, that, to me, that's where we should be looking at a metric of success, not, hey, have we plummeted back down to where everyone was living in their basements, because that's just not, that's not going to be a reality. These numbers aren't going to match that just because we weren't doing this, you know, 8 weeks ago. So.
Yeah, that's a good point. Success in public health means that you think we overreacted about everything. You know, so we don't get to prove that we were successful if we were successful. You know, because then people guess, well, maybe that wouldn't have happened anyway. You know, so it puts us in a really hard position, and you know, but we're comfortable with that. This is how we live in our careers, but it is hard to translate that to the community. You know, success is you guys thinking that we did this all for nothing.
So I think in closing on those inspirational remarks, we had a lot of questions from the community posed to us from a public health perspective. Can schools open? And where do we stand as a community? Because I don't, there are a lot of people that couldn't interpret the data correctly, or people that wanted to interpret the data in their own way, but it was incorrect. And what we're here today to say definitively is we think as of right now, our community is in yellow, tinging on orange, but we think we're in yellow, and if we can get some of these other factors in place, I think we're solidly in yellow. And with that comes, our belief that yes, you can open up school, and here's how the way that you can do it, but the specifics of it and the timeline for which you're able to accomplish that is entirely up to the school system and their ability to accomplish that. We're not here to cast judgment on that. I shudder at the significant challenges that all of you have to be able to accomplish that, but we feel it is incumbent upon our public health experts to come forward and clearly articulate where we stand as a community from a public health perspective. And we stand ready, no matter what, to support our schools as we have for years and years. We stand ready to help you guys through this difficult year and whatever comes with it. And we look forward to rolling up our sleeves and working with you in the coming weeks, months, and years. So with that, we don't want to monopolize your time today, but we do appreciate the opportunity to address you.
Well, could we go back, Ms. Helps was going through elementary should do this, and I'm sorry we interrupted you and gathered the questions. What's the rest of your recommendations?
Well, they're all kind of laid out here. Was there a specific question that you had about something?
No, I just kind of wanted to hear elementary should do this, junior high should do this.
So it all depends on the measures that you have in place, right? So if you're able to cohort very strictly your high schools and your middle schools, could they go back? Possibly, right? If you have all these other measures in place. I think that's easier to achieve on an elementary school level, and the risk is smaller from an elementary school level, okay? So partly it's a logistical thing, which really you guys need to get in the weeds on, not me. But from a risk standpoint, the risks are likely smaller for the elementary kids, okay? And then from the logistical standpoint, they're already cohorted for the most part. That becomes a lot more difficult with the middle school and high school. The middle schoolers and the high schoolers are going to be able to spread the virus with the same efficacy as adults, okay? And we've seen that, and we know that that's where it's spreading right now is our high school students and our college students. So we have to take extra measures, and that's why they're separated out and are in this extra category, right? Where we don't want them all coming back right at once. So that's why I've recommended that they go in a hybrid model unless you're able to very strictly cohort, monitor, and space.
And you would rather do 2 days a break, 2 days a break, and like Eli
Even better would
Lilly.
be a week.
Eli Lilly is doing this. You work a week on, a week off. There's an insurance company.
We would be much better from the public health perspective, but the 2 days break and 2 days would be sufficient.
Okay.
I noticed in some of your plans, it mentioned 7-day, and I think our reopening plan right now references 14. Is there a difference in those numbers, or is there a recommendation?
Are you talking about the metrics?
Yes.
You're talking about the metrics? And that's why on our metrics, we've used the 7-day percent. So 14 days gives you kind of a broader picture, and it evens things out even more, which is why from a case number perspective, we are a small community. So we're going to have wider fluctuations than a larger community. So that 14-day average is particularly important for those spikes, and that's why our bar graphs are going up and down, up and down. From a percent positivity, that's a little bit of a broader view, so we can take that into a 7-day average. We're still occasionally calculating broader term averages, so again, it's all contextual, but we kind of wanted to take some of that guesswork for you guys as a school system out from the metrics, because there are so many contextual factors.
I think, Clint, to be direct, our recommendation would be you pull out any reference to metrics in your plan and you just line it up with the colors that are here, because we don't think tying it to one specific number is the right approach, because there's so many variables to to what could make sense or what the current context is, that we think your plan should align with, if we're in level yellow, then here's what we're doing as a school. If we're in level red, then we're all home and it's not a question. We would prefer an alignment around that. And that is no fault of the schools for having used that, because that's the only data that was available at the time. But as we sat down with our team here, we said, okay, there's a big, broad conversation about all these different factors. Let's put them all together and make informed decisions. And we really think, Monica said, well, we're taking the guesswork out of it for you. I mean, Dr. Borf and the entire team, you guys aren't epidemiologists. You don't spend every day looking at these numbers. So what we're saying is, we'll take that responsibility and say, this is where we are as a community. And with it comes these set of recommendations. So that would be our thought moving forward.
Yeah, I think the metrics that you have are a good starting place, and those were just based on examples of what other places have used, So you got to start somewhere, and we've tried to craft this then, knowing that the intention was the phase plan, and once we were able to see that, we said, okay, we've got to do something broader for the community and for the schools to give this bigger picture. So that was the impetus behind this.
Certainly, thank you, because I see several things in here that I think is more detailed and helpful. Dr. Borf, I don't know how much of this, I know you've been working with the health department a lot, I don't know how much of this you've been privy to ahead of time, but as you sit and listen to all of this today, what do you see as the next steps and how this aligns or maybe may need some adjustments to our reopening plan?
What we're looking at doing right now is, first off, is this public?
Yes, so
It is now.
what's that?
It is now.
Yeah. So our intent was to first brief the school board on respect for all of you, because it had school implications. We want to talk to you today. And then this document will be provided to the community this morning on our website, so that we're rolling this out not only for the schools but for the community, as here's your weather forecast regarding COVID. Every day you can go on there and look at it. So yes, this will be a very public, and we hope heavily consumed document. At the end of the day, I think people just, they'll look at it and go, well, it's red, I got COPD, I'm staying home today. Or it's green, hey, I can start doing some things that I wasn't able to do before. But yes, this will be a public document.
And to your question, we've had an opportunity to work and to provide feedback on it. I don't know that our feedback was worth much, because I don't see it in there, and that may be for good reason. But what we're going to have to do now is look at our plan and see if there are ways that we can integrate what we're doing with that. That was not available to us, as has been said. It would be irresponsible on our part not to look at that and see if we can insert that into what we have called our metrics. And we're prepared to do that. We're also prepared to look at the whole plan, to the length of our plan. And we'll be talking to the teachers about that, the Teachers Association, because I think there are some ways that we can adapt our plan that will bring students back perhaps at an earlier point than we have planned. But we are also in school now. We have started. We have a reopening plan. We have reopened. So now it's something else. It's not a reopening. It's how we move forward. I think we have to look at a number of factors. Our staffing is one of the issues, and there's been a lot of statements about that in these presentations. We do have a number of teachers who qualify for leaves, and that will affect our operations. It will also affect the bottom line budget that I'll be sharing with you. Kim, how many teachers do we have on leave right now?
Go ahead, Kelly.
We have 26 I'm sorry, I was thinking quarantine. You were saying leave.
No, so
she was answering a different question. So right now, working virtually from home, we've got about 45 teachers who are working from home. We've overall had about 170 to 180 personal phone calls with teachers to walk through, and currently around 20 who would request a leave as we progress into our next phase.
Is that in addition, Kim, to those who are working from home right now, or does that include them? The 20 that you think would take a leave when we went to the next phase, is that in addition to those that are currently working virtually?
No, so you need
That
to
would
add,
they would be included.
they would be included.
So we're sizing that up as well. And like I said, we're working with the Teachers Association on this. We'll have discussion on it. But I think you'll see at the next board meeting, maybe as early as the next board meeting, how that plan can be adapted so that some of our parents who are concerned about the mismatch between our plan and that plan, because they're going to see that as another plan. And I think there will be some confusion if we don't try to align it in a way that makes sense.
Yeah, if we could get an update, I know it's a lot to ask for the next board meeting, because I know we want to give, in our plan, we're trying to give the community 2 weeks notice. If we don't do something this week, then our next board meeting is only like 4 days before Labor Day, and
Right.
so.
Well, there will be an update, and there's going to be an update, and maybe a look back a little bit at the next meeting, because I think there is a lot of disinformation out there being circulated, and we need to correct that in a very public way. And so as we move forward, maybe that will establish the foundation for that disinformation to be minimized, and I think we'll be moving forward in a better way.
Mayor Fennis, I appreciate this. I think this is a huge help. I know we had a lot of community members and board members, myself included, that were struggling to read the data on the dashboard, and kind of people were checking it daily, like what's our daily percentage rate? I don't think that was actually even on the dashboard. So people were trying to calculate it themselves.
I got a lot of those emails.
Emailing, like, well, I did this math, and this is where we're at, and we're at 4%, or they were misreading the 3.5% that was for like the whole time period. It was just very confusing.
Right.
So I appreciate this. I think this will be helpful. I also appreciate you being very clear that the city is not telling the schools what to do, which is another thing I've heard from a lot of people.
We can try to do too is, when we put this up on the website, I think we can put some very clear language around it that says, these are recommendations, and how the school operationalizes these recommendations is the school's decision. Like, again, I want to be very clear to anyone listening, these are not public health orders. We're not sitting here telling and mandating every specific scenario here. We're just saying, in a best case scenario, given the context of any one of these colors, here's our recommendations. And we do believe you should take them very seriously and work towards those goals. But we also come here fully recognizing the challenges you have operationally.
At what point would there be a public health order?
If things got to the point where they were looking out of hand and we didn't have the support from the schools broadly, and not just you guys, but our other schools that are in the area, which we don't have a lot of, right? So Marion County, for example, did put out a public health order related to schools, and it was very specific about exactly what they could and could not do, and who could go back and who could not. And we did not want to do that. We don't have the same needs as Marion County does to do that, because they're juggling like multiple school systems, multiple private schools, like all of these disparate ways of kind of handling how the kids were coming back to school. So they did that in order to get some kind of unity in the context of their percent positivity being around 9%, so they had to do that for very specific reasons. We do not want to do that. It would be the last option on the table, but
and to be honest, it flies in the face of what 15 years of a relationship with the school system has been. I mean, we've always come to the table to collaborate and continue to do so, and we value the relationship with the school. So you're a partner in this. We already have a health mandate. That's why we're all sitting here with masks on. I think we would be more apt to regulate individual behavior and work collectively with you on how we operate the schools than we would be putting mandates out on the schools.
Yeah, there's a lot of different ways to go about this, you know, so we think this can be done safely and we think this can be done effectively, but it's gonna take some creativity. And we know that we were sitting in a room with a lot of creative minds, and Dr. Borg's team has a lot of great people on it with a lot of creative thinking capabilities. All of our kids are excellent creative thinkers, so we know that this can be done. And, you know, we've seen examples around the country and around the world of schools that have taken unique approaches to be able to get the kids back in school and do it safely.
Under our current plan, we've stated that we'll give parents 2 weeks notice before making any changes. And we've also stated that we'll be in our, what's currently phase 1 through Labor Day. So if we're looking at potentially doing something different shortly after Labor Day at the soonest, but also knowing those decisions have to be made quickly in order to give that 2 weeks notice, would you expect that our leadership should be planning as phase or level 3 orange because we're teetering on it, or would you think we can plan level 2 because that's where we're at now?
I think, I mean, just from a public health and readiness perspective, particularly, I think it would be not unwise to start planning for an orange level phase-in, because I think that lines up well with your phase-in plan already. And that would be an appropriate way to test the system and structure that you have in place. And we're standing here ready to walk through any more tabletops or exercises that we need to do in order to make sure that we've at least tested these things theoretically before they happen in the real-time setting, and then take it a little bit slow. It would give you a little bit more time to kind of see how things are unfolding in the other schools. So I don't disagree with the idea that you guys wanted to be a little more cautious and start virtually. I fully support it. I'm all for risk reduction, but I do think we need to make sure that those plans are ready and that they're fully vetted and tested. And we're here and able to continue those meetings, and we would love to do that.
I think in the next 2 or 3 weeks, a couple things will transpire that will help affirm whether we're in yellow and orange. And so I think today, for your planning purposes, those two aren't that different in terms of what we're doing. I mean, there's a little bit of difference, but you can plan for both. We have a significant number of test results that are pending, that are out there, that are at the lab that we're waiting to get back. In the next week or two, if testing speeds up, and if we start to see results and those numbers come in positive and we start to see a decline, I think there's a reasonable belief that we're somewhere in between yellow and orange and we can figure that out. So for me, I would try to figure out both of those scenarios. Like yellow and orange is, right in the middle is where we're at right now. And right now, between now and Labor Day, you have a good opportunity to get those plans in place, and we'll have a pretty good idea of where we're at color-wise here in the near future.
So I'm hearing we probably need to look at our phase-in plan and make some modifications to it. Thank you so much, Fisher's Health Department. Mayor, I know it was Monday afternoon when we asked for this meeting, so thank you for being here on short notice with all this. I did also want to, I think we're wrapping up the meeting if there's no more questions, thank our families for sticking with us throughout this. I saw a lot of good things on social media last night. Wanted to thank our teachers for all they do, and our tech department over there in the corner, Tom Coons and Jeff Harrison, and all the people who've helped them, because I know they have worked more than they've ever worked for a school opening just in the last 24, 48 hours. And I did want to say, just kind of to sum all this up, last night I got 2 separate communications, one from someone saying they heard we were going to be virtual all year, and someone saying we were going to open up before Labor Day. So rumors are rampant. Go to the source, ask questions. Don't always assume what you hear is true. And I think speak for everyone in this room when we would just by saying we would like nothing more than our students to be in school all day, Monday through Friday. and hopefully we will get there, so.
Thank you for your time.
Thank you very much.